I won't keep you for long. Now, when I talk of familial cancer syndrome, I've been an onco. I'm not a geneticist. I'm not an expert in genetics. But one of the questions which a patient comes and asks us, my mother had developed cancer, will I develop cancer? Or my daughter, what is the risk of my sister developing breast cancer if my sister had breast cancer? These are all questions which can be asked as a clinician to you. And so I just started a statement that all cancer is genetic, but most cancers are not hereditary. Now, before I dwell a little more on this, there are two things you should know. I'm not going to bore you with a lot of genetics, but there are two things you should know about mutation. Now, cancer is caused by some change in the DNA, which we call mutation. So, most of you are already aware of what is a somatic mutation and what is a germline mutation. And you should also know something about the degree of penetrance. So, basically, for simple sake, the somatic mutation is something which occurs in a cell after the formation of the embryo. So everything that occurs after that is a somatic mutation. That occurs only in that particular organ. Whereas a germline mutation occurs in either the sperm or the ovum. And therefore, the fusion product, every cell in the body will have the same this thing. That is why in a germline mutation, you can detect the mutation even in any body fluid, even in a saliva or a blood serum examination. Whereas just because you have a mutation doesn't mean you will develop cancer. You may have a BRCA mutation, you may have any other mutation which are caused by Lynch syndrome, but that doesn't mean you will develop cancer because there are varying degrees of penetrance. So you have a high penetrance or a low penetrance. If you have 100% penetrance, means everybody with that mutation will have cancer. But that's usually not the case. There is a reduced penetrance in a lot of cases, and we don't know the exact causes of why there is reduced penetrance, but there may be a combination of a lot of environmental and lifestyle factors. So when I say all cancer is genetic, yet most cancers are not hereditary, it means that, there will be some mutation in all cancers, but most of them will be the somatic mutations. The germline mutations, maybe only about 10% of cancers are due to germline mutations. And these are the cancers which we need to know. So as a clinician, you don't need to know all the syndromes, you don't need to know all the things. But when a patient asks you, do I have the risk because my mother had cancer or because what is the risk of my sister developing cancer, then you should be able to advise them. That means risk assessment is basically what you need to be able to tell them. What is their risk and what can they do about that risk? So, genetic testing is just one of the tools to assess the risk. It is not the only tool and it is not a must do in all situations. But for a clinician, the risk assessment starts with just two basic things. One is just history of the patient itself, the personal history and the family history. These are the two things which are the most important when you're doing risk assessment for a patient. So when you have a patient with cancer, you find out more details about the cancer. You find out what type of cancer it was. If you can, they might say it is just uterine cancer, ovarian cancer, breast cancer, colon cancer, but try to find out more details if possible. Some of them may be able to tell you is it a high-grade serous ovarian cancer or not, or may get you the details of the pathology. The next question you should ask is the age and diagnosis of each cancer. Every relation who's had a cancer, you find out at what age they had cancer. Was it at 40, 45, 50, 60? That makes a difference to your risk categorization. And then look at the lineage, whether it is from the paternal side or it is from the maternal side. Now, and the degree of relation, whether it's the first degree relation or second degree relation. In simple terms, first degree is mother, father, brother, sister, son, daughter. And then second degree means when you share grandparents. So everyone, whether aunts, uncles, nephew, niece, grandparents, everything else is third degree relations. So when you take the family history, you take the personal history, and you just categorize them based on that into three risks, whether they're average risk, which is the risk of a normal population, or increased risk, which is increased or moderate risk, and high or strong risk. Now, there are many risk assessment tools which are available on the net, which can be freely downloaded. You don't really need to know them, but you can. If you have a good practice and you have a good clinical assistant or a physician assistant or a secretary who can give these questionnaires to the patient and get it answered, you may be able to give a more objective score. But you don't really need all these always. In a busy clinical practice, it is not possible to administer any one of these models always. So you just look at the family history, look at the personal history. You find out if it is what degree relation, first degree relation, what age did they develop cancer, and the number of relations who had cancer. And based on that itself, you can say this is increased or moderate risk if only one person had cancer which is at a normal age. And there are some personal risk factors, maybe nulliparity, maybe absence of breastfeeding, maybe use of hormone replacement therapy. All these could be risk factors. Or alcohol, smoking, these could be risk factors. When you have high risk factors, it is much more number of relations with breast cancer, with any cancer, breast, ovarian, colon, endometrial cancers. There could be 2 or 3 generations of cancer cases in the family, and there could be at least one individual with a younger age at all. Means when normal, you expect ovarian cancer normally above 50 or above 60, but if you have an ovarian cancer at 40, it's definitely a high risk factor. Then, of course, if some people have already done genetic testing and you know a mutation exists, then they become automatically high risk. And there are certain cancers which are more prone, like the ovarian cancer, the triple negative breast cancers, a male breast cancer especially, and even pancreatic cancer. These have a slightly higher propensity to have a genetic transmission. So what do you do after risk assessment? You say this is a high risk. If a patient asks me, now I am a high risk because of my family history, what do I do? One thing is, if you have the facilities available, yes, you could refer them to a genetic risk assessment or a high risk referral, where a genetic counselor will actually sit with them, talk with them, take the full family history, and make a detailed assessment, pre-counsel them regarding whether the need for genetic testing, whether they understand the implications of genetic testing, and then go ahead with testing if needed. But that's not always possible, that is not always needed. So you could directly just advise them based on their low or high, increased or moderate risk. You could, what are the steps you could advise them? One is for potential for increased screening. Just because you have a risk, all you have to do is a more increased screening for certain cancers. There is some chemo prevention facilities available, and there is some surgical risk reduction procedures. So these are the simple things that you could tell them. Now, if you do a genetic testing and you find a mutation, that's what you call them a previvor. A previvor, what would the counselor also advise? It's almost similar things. Some lifestyle modifications, cancer surveillance, which will be slightly more vigorous than normal, chemo prevention in some certain cancers, and risk-reducing surgeries. So what are the lifestyle modifications? Again, simple things: exercise, dietary issues, limiting alcohol consumptions, avoiding hormone replacement therapy, encouraging breastfeeding, and early completion of family, because they may need risk reduction surgeries at a younger age. Now, for breast cancer, what do we suggest? The increased surveillance actually starts from the age of 25. That means at least a clinical breast examination. That is what CBE at every 6 to 12 months. We usually start with an annual screening with MRI from the age of 25. And MRI is usually done in the first half of the menstrual cycle, 7 to 25 days or 7 to 15 days. And we start adding mammography from 30 years. So 6 monthly, you do one MRI. After 6 months, you do a mammogram. This is for the high-risk group, where breast is one of the risk factors. Now, for ovarian and endometrial cancer, you just heard also, there is very limited value for screening in ovarian and endometrial cancer. It is not advocated as a routine. So, but you could, because the patient is anxious, because you have to do something, sometimes you do offer them concurrent TVS, transvaginal ultrasound, and CA125, which could be done, usually done again in the first half of the menstrual cycle. For endometrial CA, again, screening is not recommended. You just heard from the previous speaker. But a pelvic ultrasound and an office endometrial biopsy can be done in the real high-risk cases or those who have symptoms. The most standard thing that you could advise for many of these conditions is risk-reducing surgeries. The risk-reducing surgeries are the way to go about for most of these things. And for it is usually the bilateral risk-reducing salpingo-oophorectomy is a standard for ovarian cancer risk reduction. Oral contraceptive pills have a protective effect for ovarian cancer, and especially those in BRCA mutation, oral contraceptive pills can be advised. There are certain hormonal therapies. Sometimes we use tamoxifen or raloxifene to prevent breast cancer, sometimes in cases of those who are BRCA2 mutations. And for endometrial cancer, especially those with Lynch syndrome and all, hysterectomy is the way to go forward. That's the best risk-reducing strategy that you can offer. So, in conclusion, all I'm saying is, for any person walking into your OPD, what do you have to do? You just assess the risk and categorize them. Are they average risk, high risk, or moderate risk? And then this is based on the personal history, that is the patient's own history, if they have a history of cancer, or if they have other personal risk factors like alcohol, smoking, or use of hormone replacement therapy or nulliparity. Genetic counseling is definitely advisable if is available and if the person is motivated. But based on risk categorization alone, you could advise them either an increased surveillance or risk-reducing approaches as is appropriate for each case. I won't keep you longer than that. Thank you.